Hello, everyone, and welcome to today's webinar. I have a few announcements before we get started. If you need technical assistance during today's event, please type your questions into the questions box, which is located to the right of the camera window, and click the submit button. You can use the same box to submit questions to our speakers at any time, and if we don't get to your audience questions today, we will try and follow up with you offline. The questions box has multiple tabs where you can view any webinar handouts if available, as well as the abstract, speaker information, and access your certificate of completion. Finally, you will receive an email by the end of the day with a link to a replay of this webinar as it becomes available. So with that, I'll hand things over to Jonah to begin the presentation.
Hi, I'm Jonah Comstock, Editor-in-Chief at HIMSS Media. Welcome to Creating End-to-End Patient-First Experience. The patient's experience with the healthcare system starts before they walk through the door or log into their telehealth portal and ends long after the end of their visit or procedure. In this webinar, we'll speak to patient experience design experts of how to create a positive holistic experience for both virtual and in-person care across the patient journey, from first contact to last follow-up. And to help me with that conversation today, I have Dr. Thomas Howell, Assistant Medical Director of Patient Experience at the Mayo Clinic, Chris Brereton, Partner and VP of Product at SideBench, and Vishaka Sant, Global Head of Healthcare Providers at ServiceNow. Thank you all so much for joining me.
Thanks for having us.
Thanks.
So let's start by giving you each the chance to introduce yourself a little bit and tell us about your work and how it connects to this idea of patient experience and the patient journey. Let's start with Vishaka.
Sure. So, thanks for having us on here. And just a little bit about myself. My background is really in bridging together technology that can be embraced by patients and by providers in context of their needs. And at ServiceNow, I'm accountable for driving healthcare strategy solutions. So what that means to patients is anytime that there's a workflow or anytime there's a need to collaborate with the provider, healthcare institution, or the clinicians, there's solutions that can be brought to the market that allows them to have, easier access or really understand what they need to do in order to have the most optimal experience. And on the flip side, for the provider organizations, really understand how can we make workflow better across the organization, and how do we know where the bottlenecks are? That could stem from your administrative practices to your patient care practices to your clinical interactions with the providers themselves. And so my lens is really looking at across the patient and the providers, how does technology really help enable ease of use and really getting the best outcomes intended for that patient.
Thanks. Let's go to Chris next.
Hey guys, I'm Chris from SideBench. I've been a product-centric entrepreneur my whole career. Built and sold my first company in my 20s that was essentially a Squarespace for the nonprofit ecosystem, large-scale chapter-based organizations. Since then, I've joined SideBench as a partner. I oversee product design and engineering here. We work in partnership with a lot of healthcare companies on all sides of the market, be it patient, provider, or payer sides, in many different capacities. So excited to share our experience with you guys.
And I'm Tom Howell. I'm an OBGYN. Half of my FTE is just doing normal generalist clinical work with my practice in a small town in Minnesota. I've been doing that since 1991. I serve as the community division chair for the Department of OBGYN for Mayo Clinic and the assistant medical director for patient experience. And the patient experience work has really morphed into moving from two things that we always were historically, almost since the 80s, which is the complaint department and the keepers of the sacred survey data, right? And now we're looking at that much more holistically in the experience across the continuum of care and interaction, the experience of our staff, experience of our physicians and advanced practice providers, as well as the experience of our patients and their families, and as an extension of the community. So really have moved that thought process to a much bigger idea that is very intertwined across the continuum of the healthcare industry.
Thanks, Tom. That's a great segue into our topic for today. When we say patient experience, I think a lot of people think about something very narrow, the experience of the patient in the exam room as they see the doctor. But of course, a patient's experience with the healthcare system includes everything from appointment booking to follow-up care, as well as things like parking, wayfinding, hospital food, and the digital experience of care is even broader. So when you guys think of patient experience in your work and the work that you do, what's your framework? Where do you draw the lines? What are all the pieces that you consider? Anyone who wants to start.
So I'll jump on that and then see what the other two have to say. I think the goal is to not draw the lines. I think it is to understand that it's everything. And at the same time, it's that whatever the experience is in that moment. And all of those things matter. So, just like if you go to a great restaurant and everything is fine, but the soup comes out cold or parking was horrible or whatever. Healthcare consumers and patients, I hate to call them consumers, although that's kind of a reality, I suppose. Patients are becoming into that mindset where we really expect you to be good at everything. I think that for a long time, providers and physicians in particular assumed that we were nice and pleasant and connecting to folks, and that our technical expertise was the difference. I think the reality is for patients, they assume you were technically competent, right? Or people wouldn't let us do what we do. And the differentiator is those experiential, those relationship pieces. So I think the goal is to draw those lines, if you have to, as broadly as possible, and make sure you're making them at least competent across all the parts of the journey.
Yeah, I think that, adding to that a little bit, the way that in my experiences across, I'm from the industry, I worked with Kaiser Permanente for the last 11 years before joining ServiceNow. And I think about this notion of patient experiences, and I kind of coined this term called create, right? So the C is really stands for like caring, right? This is not a transaction. It's an ongoing relationship, irrespective of where that patient is at in the life cycle, whether they're shopping for the service or they're receiving the care or they're post-discharge at home having to do a treatment plan. And in this age of consumer, there's this notion of being responsive, right? So are responsive right here, right now, and in the way that they actually want it in context. I think in terms of, the ease of use, keeping it simple, digital experiences should be easy to navigate, right? I mean, think about things like the iPhone came up, we didn't even know we needed it until it's proliferated, it's everywhere. And there's no large manual to let you know how it's used. It's just kind of intuitive. Agile. So I think COVID has really taught us the salient, resilient, and flexible organizations are the ones that are going to actually survive in the years to come. And from the standpoint of the T, it's really technology with a purpose. I've worked for organizations where, there's nice shiny objects, but, what are you actually delivering with it? I think, what are you trying to enable? And we can't forget the platform and infrastructure. There is key to the patient experience as, the actual users and the clinicians that are delivering the care. And then the last one, E, which I think is more up and coming, is just equitable, right? Making sure that there's fairness, that it's equal, that, for providers and for patients alike, it's affordable and accessible. Nobody should have to be limited just because things are digital and they might not have access. The playing field should be very flat right now. And so that's kind of how I think about when I think about design and patient experiences. I kind of categorize it in this notion of create framework.
I love that. That's awesome. The one thing that's a guidepost for us when we're thinking about these things is sort of what is the outcome or the overarching goal we're trying to achieve with the experience, and not dissimilar from any other non-healthcare products that we work on. We think a lot about the entire customer journey end to end. And while we may only be impacting a piece or two of that journey based on a particular product we're working on, we try to gather the context related to each step of the way before and after you're engaging with our thing and your personal setting in those moments. So that really guides us in determining how to design the experiences, not just sort of build a beautiful UI that works to accomplish the task, but how does this serve the person in the moment that they're in that particular context that they have. But I love the create thing. That's really cool.
All three of you have touched on some things that I want to dig into a little bit later in the webinar. So, so I look forward to that. But first, I want to just sort of get some best practices. You know, when you're trying to build this end-to-end patient experience, what are some of the biggest pitfalls and what are some of the most important things to keep in mind?
I can jump in first on this one. I think a lot about access and sort of access and accessibility. So access meaning access to technology, access to transportation, access to in-person care, and then what is the accessibility of the individual experiencing each of those, or maybe not experiencing each of those different settings. So if we're missing the context or not being inclusive enough to think about the person who's in rural America and isn't able to get to that physical experience that we're designing an appointment scheduling platform around, we're missing a ton of opportunities to support a lot more people. So that's sort of the like check for us in designing a healthcare experience is, are we touching these edges and are we being equitable and thinking about these different contexts or accessibility criteria? And that drives a lot of the upfront product discovery process for us.
Yeah, and I'd like to add that, you know, the feedback, right? The feedback that's collected and being able to, you know, Dr. Howell mentioned that, you know, the complaint department, the survey data, it's great that you have those mechanisms to kind of get the voice of the customer, but if you don't do something with it or you wait too long, and now in this digital age, there's ways to intercept the feedback as it's being given, right? And so I think making sure that you're actually doing something with the feedback that then leads to some sort of noticeable changes. And then the other thing is, you know, personalization in the digital era, right, is key, right? Amazon, Netflix, they know us, they know what we want suggested for us, and then we want it, right? And this whole notion of personalization does not mean customization, because what we try to do is have standardized, you know, workflows or standardized, you know, platforms and processes that allow us to touch on personalization without having to get into heavy customization, which then leads to technical debt or, you know, a lot of investments in technology to then upkeep and upgrade. And then I think the last thing is, as we learned also from the pandemic, right, is there should always be this option to go back to a human. And I think I've learned that. I think, you know, my colleagues have learned that digital doesn't always mean that everyone's, you know, gung-ho about it and they want to use it, right? There should always be an alternative for those people that need to have the one-on-one. And I think that as we consider these digital channels of engagement, that we should also think about how do we actually offset that so it is equitable and that people have their channel of choice, which could also mean a human interaction.
Yeah, I think, Chuck, you make a good point, and I kind of try to paraphrase that in saying that, you know, for patients, it's not customization, but what they want is they want us to know, they want to be known and understood. And the fact that you know me and you understand me doesn't mean that you build everything specially just for me, right? I do think that we learned a few things during the pandemic, and one was to challenge assumptions. You know, our older patients aren't going to be able to adapt to the digital thing, to virtual visits. Absolutely 100% not true. Everybody has access to the ability to do virtual visits. In the upper Midwest, especially in rural Minnesota and Wisconsin, 20 to 25% of our patients don't have broadband. So, you know, we can try and virtual them to death, but the infrastructure isn't there. So you have to find a different way to look at it. And then I think something that's been known for a few years is that in the journey, wherever it is, and I'll use like an inpatient admission as an example, there are key points that people remember. So, the reason we maybe remember things vividly from high school is because there was something that happened at that time that was very emotionally connected to it, right? High level emotions connected to this. So for patients in the inpatient world, we know that the time of admission and that transition into admission is really important. Probably into first day, they've started to experience some of the care system and some information's come in, and then they're discharged. If you get those three things right, they'll give you a lot of grace and other stuff. If you get one of those three things wrong, it's hard to recover from those things. So recognizing that although the entire journey is important, there are specific points that are really impactful, and making sure we get those things correct.
So true.
So much good stuff there. I want to zoom in on this idea of technology. I mean, and we've all talked about it. I really liked what you said, Vishaka, about technology with a purpose, right? Do you guys, when you're thinking about patient experiences, what role does technology have to play? And like, what are some productive and unproductive ways of thinking about your technology when you're thinking about building an experience?
I think to an earlier point, technology and being able to collect information that you then don't respond to is a very unproductive way of dealing with it. So in medical school, you're taught, don't order a test. It's not going to change your management. It's not going to give you more information. Don't just get it to get it. And I think that oftentimes as we rolled out technology and said, gee, we can find out this, or we can ask people about thing X. If we're not going to do anything with it, and especially for that individual, if they have a concern or a complaint and we can't respond to that, even though we're going to use it internally to do more stuff and change maybe how our workflows are, that's really disenfranchising to that patient and really turns them off. So we need to be careful about if we ask for your opinion, that we do something with it. I think that's a great example of what not to do and how not to use the technology.
Yeah, I think it's not always just about the technology. I guess it should probably never just be about the technology either. Like if we're creating tools and systems that save time for providers, for example, how does that time then impact the patient in a new positive way? Instead of having to sit there and collect information into an iPad, for example, that's taking the attention away from the visit, how could we pre-collect that information in a less impactful way that gives the physician the opportunity to have a more interpersonal connection in the moment? So it's less about does the tool do the thing and more about what does the tool enable because it's done the thing for me, I think is how we think a lot about it.
Yeah, I want to just jump on that, Chris. One of the things that I think we're not very good at is collecting that information ahead of time, and then collecting that information again.
Yeah,
and not using it. Didn't you ask it? I always tell people, the worst thing you can do is walk into a patient room and say, "Hey, what did cardiology say?" It's like, don't you guys talk to each other? Why do you even bother doing that? But we're doing the same thing to them if we ask them a bunch of questions up front. And then they show up and the nurse gets out her iPad and starts asking them all the same questions.
Absolutely.
Yeah. Or if I go in the waiting room and get handed a clipboard and told to write my address every single time I come to visit, right? Like, do you have a computer?
Right.
Yeah, I think this notion of the transfer of knowledge, we have so much information that's being collected, but if you don't transfer it, even if you think about, calling into an advice center, then being transferred over to some other agent, then finally, getting on the phone with someone else, and you're being asked the same questions over and over again. That's not a great patient experience, and it's really a waste of time for the provider organization as well, right? Because somebody's already collected this, and so I think some of the downfalls is just that transfer of knowledge. Over communicating in some instances, right? Like through the use of these notifications and the text messaging, sometimes like phones are being blown up with reminders and, here's your scheduled, appointment. Here's a reminder for it. Press C to cancel, press C to confirm. And I think you have to really be very mindful about how much you're communicating to the patient or at the patient, right? And I think it needs to be welcomed. So being able to be very mindful of the preferences that the patient has set forth is super important, not only for themselves, but even for their household and the family members. I think when you do it well, right, you're using that data to actually make intelligent and proactive decisions, and even look at, digital behavior, right? So some of the things that we look at in terms of the data that we found in my previous organizations was, before an ER visit, did the person go online to try to schedule an appointment 24 hours in advance? Could we have intercepted that somehow? Because there's some, outcomes for the patient, and then there's financial, benefits to the organization also to keep them out of the ER. So I think being able to look at these different data points and bring them together in a manner that actually helps the organization target some outcome is a great way to use the technology.
It occurs to me that one thing that can be missing from these conversations is the context of patient experience as a priority that competes with other priorities. So when you think about why does my doctor ask for the same information over and over again? Well, maybe it's because they're worried about HIPAA and their systems. And if they can't have it talked this way, because then your information will have to go through a place where it's not safe and secure. Or, maybe they're worried about, some other piece of interoperability. I mean, maybe these two systems just can't talk to each other because they haven't figured out how to make that work. So
that's a huge one.
How do you make sure that patient experience stays a priority among all the other priorities that exist in a provider organization?
So we have done this exercise and are in the process of getting everybody to really buy into it. And a lot of, in the midst of kind of the explosion of safety ideas and metrics in healthcare, there was a communication framework called SBAR, so situation, background, analysis, and recommendation. Right, everybody did that, and it came out of emergency type situations where you want to convey specific information in a specific manner that can be received, that people can acknowledge it, to receive, that you can do something about, and your expectation on what I need you to do with this is clear. And so that's been rolled out, and people can overdo that. I had when we started doing this, I had nurses send me notes that said, Mrs. Johnson needs birth control pills. Situation, Mrs. Johnson is on birth control pills. Background, she's out of birth control pills. Analysis, like you can do it to death. But what we did was, and we went up to the highest levels of the organization to get approval for this. And it's slowly being adopted, much slower than we would like, as most things, but it is being adopted, that we stopped calling it SBAR and started calling it SBEAR. So it's as capital S, capital B, capital A, small e exponent for experience, and then response. So everybody, when they roll out some kind of a new policy or a program, will have to do some kind of a financial effects analysis. And we said you should need to do an experience effects analysis. And that can be as simple as answering the question, if this changes, how is it going to affect the experience of patients, families, and our staff? And that can be a 2-second or a 2-sentence explanation, but we'd much rather have that evaluation done on the front end than have it done 6 months later when we say, yeah, this is great efficiency-wise for the practice, but it's horrible for the patients. And now we're backtracking and trying to, reconfigure this thing and make it better. So I think that if we can get everybody to do that whenever they have a communication around policies or procedures that are going to change, I think that'll be a big leap forward for us anyway.
I love that.
That's great. For us, it's a little different because we're not the ones necessarily setting the priority in the organizations. However, when we're anchoring our work to the outcomes we're trying to create for both the patients and the care company in whatever capacity we're working, there is always sort of a user value and business value that we're anchoring to. And that business value drives a lot of really strong conversations and priorities. When we can reduce the amount of people on a waiting list and drive speed to care, for example, that results in real revenue to the provider in that instance. And that's a really useful way to prioritize what also creates a great patient experience.
Yeah, and I think we're very, similar in that we align to strategic priorities of organizations and figure out what the imperatives are. and then take those into business outcomes, which typically are measurements of, automating, resolution time, or reducing some sort of a, vulnerability in terms of risk, and really figuring out how the platform aligns with that. So, I think it all kind of goes back to this notion of enablement, and we complement a lot of these various systems that don't necessarily talk to each other, which then causes this ask of multiple questions over and over again. And then sometimes it's just that there's not an easy way to document this information so that it's transferable. So, I think that what we bring to market is the ability to actually have that level of automation and engagement that can sit, across any of these other systems, because interoperability is huge, right? And not every system, some of these systems are very antiquated, and it's a lot of investment in trying to upgrade, rip, replace, all that. So I think that's just some of the inherent challenges we're facing in healthcare. But then I also feel as though the regulatory landscape and the interoperability landscape is allowing for more and more of the sharing of information from these closed systems, to really allow for greater communication, so that a lot of this redundancy doesn't exist as much in the future.
So Vishaka and Tom, I think you both mentioned how the human interaction piece is an important part of the patient experience, and no matter how much you improve your systems and your technology, there are going to be moments where a patient or a healthcare consumer interacts with a human, whether it's their doctor or the front office staff or someone else. How do you extend this idea of prioritizing experience to workforce management and staff training, and making sure that the actual experience of interacting with the humans in the healthcare system is a good one?
Yeah, I think, what we really look at is personas. We are personas based. We really try to understand who's the persona that we are targeting, and, what are we trying to solve for? And then really understand what are those touch points that we have with that persona and all of the stakeholders that might interact with that persona, because each of those touch points is like a way to establish trust, right? And we might do that in different ways. We might try to find out through focus groups, or, ethnography studies, or even still, voice of the customer, or through some national market research groups, right? And then I'll tell you, one of the things is really, if you leverage your digital platforms accurately and you look at the analytics and reporting behind it, things like multivariate testing, A/B testing, where you have one set of experiences for a user group, another set for a user group, and figure out which one actually leads to better successful outcomes. I think that really helps us understand a lot more than what we might be able to also verbally determine by having these conversations. And so what we do is we have a look at all of those things and try to figure out what is the best approach forward. And so I think that, that's really how we try to incorporate, like, who is it that we're solving for? What are we solving for? And then the analytics as to how do we actually go about solving for those things.
That's great. That's very in line with how we think about it. It starts first with the user or user types, if there are many. And then we do a lot of upfront design and prototyping and validation, and trying to prove to ourselves that we're on the right path. Our sort of internal metric is we're 70% sure that this is the right direction before we build anything. And then we build the thing, and we release the thing, and we validate the thing again and break it down and fix the thing that's wrong based on the analytics and understanding how people are actually performing against our hypothesis in question.
We again, going back to the old days and experience where it was, how do we measure something? How do we measure satisfaction? What are we going to do to improve that metric? And then maybe if we were lucky, we'd get, why does that matter? And we flip that on its head. It's this old Simon Sinek thing, start with why. Why do we care about that? And we've tried as much as possible to link this to our core values. And then to ask our staff, how does this link to your core values? Because something's going to be coincident, right? If they're not, someone's in the wrong position. So we would ask that question, and then, what are we going to do to help you live out those values and coincident with our values to improve everybody's experience? And then we'll talk about how we're going to measure success later. But that's really helped our staff to understand that this isn't a bolt onto your work. It's not something we're doing because we're going to move a metric. There's no nurse that works harder with a patient so your hospital can get extra $125,000 in HCAPS money from CMS. But they will do something if they think we're really doing this for the needs of the patient. And that's why I'm in healthcare in the first place.
Yeah.
So I think that start with why philosophy and having it be, this isn't extra to your work. This is your work every bit as much as making sure the IV is running correctly or you're operating on the right person. All those things matter just as much.
Yeah, I just wanted to add to that notion of like, this is not extra to your work. That's so super important, right? I mean, they're already bombarded with so many devices and, signals and beeps. And, I think that one of the things that Dr. Howell brought up is really important is that in order for it to be widely adopted, it needs to be a part, not an additional part. It just needs to be a part of their day-to-day workflow. It needs to, sometimes we just keep stacking work and work without necessarily taking something away. And I think that, there's so much burden out there. There's already burnout out there. And so as we all, as leaders, think about designing experiences, that whole notion of it needs to be seamless and not add more is a very important takeaway that I feel is extremely important for adoption and efficacy. And then, getting to, again, what's the value that's being generated?
Right.
I think that it's important that, because the burnout thing is very important. And I think it's across everybody in healthcare. I think COVID showed us that. But the reality is we approach burnout largely as a resiliency issue. You're burned out because you're not resilient enough. Catch on that, go learn yoga and you'll do better. And I think the reality is that, and we've done some research on this, is people are not burned out because their job is too hard. People are burned out because you made it too hard to do their job. And the closer you can get that functionality to their values and their day-to-day, with a part of their work, the better off you're going to be.
It's interesting, you can't really extract patient experience from provider experience, right? A provider, and by that I mean anyone who interfaces with the patient, if they're having a really bad time, it's a lot more likely that the patient is also going to have a bad time in that interaction.
Well, and we approached it for a long time as at the expense of, we're going to improve provider experience at the expense of patient experience. Or more commonly, we're going to improve patient experience at the expense of our providers. And that's not a long-term sustainable idea.
Yeah. So I want to talk a little bit about design thinking. Chris, you could maybe take the lead on this one. I know that's sort of your sweet spot, but I'm sure all of you, involved in this sort of, there's a piece of patient experience that's patient experience. There's a piece that's, about design and how you go about getting it to where you want it to be. And so I'd love to talk about that idea a little bit. And then after that, talk about the voice of the patient and how do you make sure you're checking in with that actual end user. So
yeah, thanks, Jonah. I think design thinking for us is probably less about what normal people would think is design of what color, where does the button go, how are the pixels organized. I think design thinking is more about keeping the human at the center of the equation all the time, right? Like we can spend a ton of time thinking about systems that will reduce the amount of time it takes to do X at the expense of the patient who's experiencing this on the other side of it, right? Like we just kind of touched on. So for us is really designing tools with the human and their context in mind first, and then backing into the business outcomes second. And it's really the anchor to the whole entire journey for us, the sort of the centerpiece, I guess. To say it again one more time, it's really not about the imagery or how something looks, feels, reacts to the end user. It's about the end user's context and how they get the experience out of the system we're creating.
Anyone want to add to that?
Yeah, I'll use one of my favorite analogies. So I can't take credit for this. I have a child that works for a large EHR company, or did till very recently, and he would listen to myself and his sister, who's a pediatrician, complain about the EHR and say, if the problem isn't the EHR, what you used to have is a hammer and a nail, and you would take the hammer and you'd bang the nail into the wood, and it worked okay. And then what we gave you was a pneumatic nail gun, and you didn't change your workflows or your processes. You took the pneumatic nail gun and you turned it on its side and you bang the same nail, and it feels clunky because you're not using how it's designed. And I think that you always have to, when you're doing design thinking, even bringing a new piece of technology on, go back to that. How's it going to affect experience? And how do we relook at our workflows or our processes? Because with EHRs, we took our paper processes and just jammed it into the EHR. Mm-hmm. We should have blown up the paper processes and just got rid of them altogether, and including the government doing what they're doing now and saying how we judge how difficult a visit is and how you code and charge that needs to be looked at totally differently. But we didn't do that. So it felt really crummy for people and really crushed our ability to do things quickly and efficiently. So I think that it's always looking at, is this an opportunity for us to redesign processes and workflows to optimize this new technology and design those things together, versus just say, hey, there's this, to Chris's point, this shiny new thing, and where do we put the green button?
Right.
Which helps a little bit, but really doesn't leverage at all that technology in the way we should.
That's a challenging analogy, though. The software design of the EHR didn't take into account the opportunity to consider the workflow of the person using it. Instead, they just replicated the paper and said, well, here's our really cool pneumatic nail gun, go figure it out. Like, that's not design thinking either, I suppose.
Would it be going too far to say there's no such thing as user error, right? The user error means it wasn't designed well enough.
Mate, that's hard.
or sometimes it's just intransigence. I mean, we're just stuck in our world that we're in.
Yeah. I think it's an interesting argument to be made between, protecting the art of the possible against the art of the probable. And, just because we want to dream big, we want to, solve a bigger problem. In reality, I think it's super important to stop and condition a big idea to something that's more scaled down and achievable. And there's missed opportunities, right? That have been discussed here. But I really do think that those two kind of conundrums and being at the middle of it is like a very sweet spot to where you might be fixing something, delivering something new, but not going so far into designing that it's not usable, or it's just, helping a small fraction of the use cases that it might be solving for. So I think this notion of art of possible versus art of probable is very key when you think about design thinking. And, as Chris mentioned earlier, like kind of the journey and the multiple touch points, there's different things that you have to think about, even from a platform standpoint and the investment standpoint. And what's the best way to get to this notion of having a better user experience without necessarily just throwing money or people at it.
So the other piece of this design thinking, patient experience design, is bringing the voice of the patient in, right? Designing for them by, making sure you have a means to figure out what their experience is like, what they'd like it to be. So how do you guys approach that? What do your feedback mechanisms look like?
I want to hear more about Dr. Howell, your complaints department. I think it's labeled interestingly.
Yeah, so we've changed, it functioned as a complaint department. Now it's the Office of Patient Experience. And we're moving towards it becoming, you'll like this better probably, the Office of Very Helpful People.
That's awesome.
Nice.
That's awesome.
Because if you think about, so for instance, Rochester, which is a destination medical center, people come in from all over the world with very complicated problems. Sometimes they have to be here for a long time, several days at a minimum. And it's a small population of 125,000 people. So it's a small town, an hour and a half from any major city. So where do I find a vegetarian meal? Where do I do all of these things, right? There's a lot of logistical stuff for patient's journey that we don't think about, that we should have a place that they can go to. That can be done in an automated fashion. It can be done digitally. There can be a spot, and I think you need all of those things. So, we do capture some voice that way. We're moving to be able to, through natural language processing, collect this huge amount of data that comes in by surveys and through complaints and through compliment letters and things that people stop and leave at the front desk, and be able to categorize them, get them to the providers when they need to be corrected, get them to providers, more importantly, when they're positive. So they say, hey, Mrs. Johnson said this about your care. Thanks a lot. That's really great. To be able to leverage that. And there wasn't really a very good way to do that in the past. So we have a whole group that's working on that currently to capture those. In the past, it was, I'll put together a focus group, or we had patient family advisory councils, which largely in small communities were comprised of 4 or 5 people who had an axe to grind about one thing or another. And you gave them pizza and they ground their axe, and then next month you gave them pizza and they ground their axe. So there's got to be more creative ways to capture that information, and I think we've made a big leap to be able to do that. And the focus groups are around a specific question, and then we move on and augment that with all the other information that we're collecting.
And then, as you said at the beginning, you actually find a way to use that information, right? Put it into practice.
Yeah, I think it's super important to be agile as we develop our products and our solutions, right? And being able to iterate very quickly and get it out in front of the consumer as soon as possible, right? Whichever customer, design partner, get it out there. And and not necessarily just the people in power, but people who will be using it, the people of passion that will be using your product. It's very important to try to get that very quickly early on and over again, so that you can stop, change, and it's just very iterative. So in the beginning, when I was mentioning you have to be able to be agile and scalable, it really does lend itself into product development, solution development as well.
Yeah, I think for us in the software layer of all of these things is we started with the hypotheses that we thought we were going to affect some sort of change. We have the experience or the engagement layer that's hopefully happening to lead that thing to become true that we can manage and measure against. And then there's the end of those moments when we can check in with something like CSAT or NPS, and we get this sort of continuum of experience that we can listen to that's not necessarily direct to an end user, but we can cohort into different experiences and different types of users and start gleaning insights from to improve the process. But it's tough sometimes with regulatory to get down to the patient level when you're a software provider like us.
Sure. Which sort of touches back to our conversation before about the competing priorities and all that we have to deal with. We're coming to the end of our time, so I want to just ask a big question to end. Stepping back from your individual organization, what do you think are some of the biggest challenges today to designing great patient experiences and designing the best experiences that you can design? And what are some larger steps that could be taken in the industry to overcome them?
Big loaded question, Jonah. One of the things I think that's tough in this area is just the holistic end-to-end experience. There's a lot of disparate systems that need to talk and aren't owned by the same surfaces or parts of the system that need to come together to make a nice holistic experience. You're seeing a lot of the more modern healthcare companies try to own that journey end-to-end, which is creating really cool software opportunities to sort of own that end-to-end experience with a particular type of care. But that's where we see some challenges. Regulatory is always a challenge. Data and how we share data and the many different standards all trying to be the standard is a challenge, with the HL7s and so on. So I think it's the holistic, the data portability, and then the data standards of how we create the system of data behind it.
Yeah, and then I think the other challenge, in addition to what Chris brought up, is, in healthcare, we're designing for a large population of patients, which looks at different demographics, different age ranges, different condition management. It's a population-based design thinking, right? So this notion of one size fits all is, you kind of have to think about it from that approach. And you also have to think about like this notion of like multi-agency, right? You have your payers, you have your pharma, you have regulatory, you have providers, you have, the systems, and then you have partners, distribution channels. And all of that is what makes up our healthcare system. And I think as you think about design, it's very hard to solve for each one of those things, but yet you need all those things in order to actually have successful outcomes and generate value. So I think that those two are big challenges that we all have to face, especially in software development, as we think about what's best for the customer, right? And I think just going back to what we've said, first we have to nail down who is the customer, and then try to figure out across all of those various roles, what's in it for them and how will they be using our system. So it's a fantastic landscape to be in, but it is fraught with a lot of agencies that need to be considered when you think about delivering equitable quality care.
I think clearly the rapidity of change, COVID moved us probably 5, maybe 10 years down the road in a lot of instances to where we were kind of going, but to some extent, dragging our feet, kicking and screaming along, and we just did it because we had to do it. Sometimes, we flipped from in-person visits to virtual visits in a week. Wow. And now we're working our way back and trying to find out where that spot is. So I think that's an example of, these aren't problems to be solved. There are a bunch of competing interests to be managed. And for different specialties and in different places, the right mix of virtual versus in-person visits is different. It's very much different if you're doing post-op visits than if you're doing intake visits with a complex gynecological problem. So I think that that's one thing. The other thing that still is going to continue to be a problem is our incentives don't help us align with thinking about this end to end. They align with us thinking about it transactionally, and sometimes at the expense of end to end. And until we're able to manage that and think about this truly as a population and across a very long continuum, even something such as employer-based health insurance that every 2 years comes up for renewal, is a recipe for me jumping as an employer from one health insurance company to another, because I'm just going to pick whatever the cheapest one is, right? So if I'm that insurer, I want to do as little care as possible, and I really don't care about preventative healthcare very much, because I don't care 2 years from now. I'm not going to have that group of patients. I'm going to have a new group of patients because it's just that churn. So those incentives have to be looked at and have to be addressed for us to really be successful at this long term.
Well, thank you all so much. This has been such a great conversation, great group, a lot of good back and forth. Thank you all for tuning in, and I hope you've all learned some things about patient experience and how to improve patient experience in whatever work you do. Thanks, of course, to our sponsor, ServiceNow, for making this webinar possible. And with that, I will hand it back over to Bridget.
All right, well, thanks so much. We will close out now, but I just have a couple reminders for our audience before we go. A survey will pop up on your screen at the end of today's event. So if you would take that and share your thoughts with us, we would really appreciate it. And finally, as a final reminder, today's session will be available on demand through the HIMSS Learning Center. So feel free to come back and watch at any time. Thanks, everyone. Have a great rest of your day.